Hello and welcome to Cancer Speak, the official podcast of the American Cancer Society journals. I'm your host, Dr. Daniel Morgensztern, professor of medicine at Washington University in St. Louis and chest and lung disease section editor for the journal Cancer. I'm joined today by Dr. Emiliano Calvo and André Mansinho to discuss a new supplement published in Cancer focused on recent advances in antibody drug conjugates. Dr. Calvo and Dr. Mansinho, welcome to Cancer Speak. Thank you very much for joining us. Let's start with introductions.
Hello, Dr. Morgensztern, Daniel, and all the listeners of Cancer Speak. Thank you very much for the invitation. It is truly a pleasure to be with you today. My name is Emiliano Calvo, the senior author for this paper, and I am a medical oncologist and a clinical investigator specialized in early phase oncology clinical drug development, or as we sometimes like to say, a phase oneologist. It is a field to which I am fully dedicated since 2003, more than 20 years ago. I am based in Madrid, Spain, where I work at START-CIO, caring for patients through treating them with innovative phase 1 clinical trials. Our center is part of START, which is considered to be the world's leading international network dedicated to early phase oncology clinical studies. And many years with this organization since 2008, I also serve as the president of START in Europe.
Hi, Daniel. Once again, many thanks for the kind invitation. It's also a pleasure to be here at the Cancer Speak podcast. Like Emiliano, I'm also working fully dedicated to phase 1 trials. I actually started my journey in 2017 with Emiliano in Madrid. Right now, we have a START center open here in Lisbon, which is also fully dedicated to phase 1 oncologists. And I work at Hospital Santa Maria, which is actually the largest hospital in the country. So we fully dedicate ourselves to investigate new drugs, and we are talking about ADCs in this podcast.
Thank you. ADC is my favorite subject, so we're heading to a good start. So just as an introduction, antibody drug conjugates are composed of three components: the tumor-specific monoclonal antibody that binds to antigens overexpressed in the surface of cancer cells, a cytotoxic payload, and a linker to connect them. As of today, there are currently 8 approved ADCs for solid tumors. The main payloads are topoisomerase inhibitors and monomethyl auristatin E. And except for trastuzumab and Thompson, all other ADCs in solid tumors have a cleavable linker. There are many ADCs in development, and we expect at least some of them to be approved soon, which will expand the treatment options for patients with solid tumors. This is the main reason why we decided to assemble a team of experts to write this important supplement on ADCs. So I'm going to start asking very tough questions to our guests. The first question for Dr. Calvo. Dr. Calvo, I wonder if you can briefly explain the mechanism of action for the ADCs, with the important steps required for its effect on the target tumors.
ADCs represent one of the most elegant ideas in cancer therapeutics, combining biological precision with pharmacological potency. These drugs are composed, as you said, Daniel, of 3 parts: an antibody that recognizes a tumor-associated target, a linker, and a highly potent payload. The antibody guides the drug to the cancer cell, binds the surface antigen, and the complex is then internalized. Once inside the cell, the payload is released and induces cell death, often through DNA damage or microtubule disruption. Some ADCs can also generate what we call a bystander effect, meaning neighboring tumor cells may be affected as well, which can be valuable in heterogeneous tumors as we usually deal with. And what is especially important is that we now understand that the success of the ADC depends on far more than only target expression. It depends also on molecular engineering, the linker stability, the tumor biology, intracellular trafficking, and exposure to the ADC. So these drugs are no longer simply targeted chemotherapy. They are precision delivery platforms, and they are reshaping how we think about systemic therapy, actually.
Dr. Mansinho, talk about one of the issues that I have. So of the 8 approved ADCs for solid tumors, 3 have a topoisomerase 1 inhibitor, 3 have MMAE, but it seems that for the ongoing studies, the vast majority of the ADCs are being tested with topo 1 inhibitors. So that's a problem when we try to do sequencing. So if you could describe the mechanism of resistance and how we can sequence those drugs if they all have this similar payload.
Thank you for the question. It's actually a very important matter as we are having, several ADCs approved for the same indication. So sequencing will be a necessity. And I would say that resistance to ADC is rarely a binary on-off event. It's like a layered failure of the delivery chain. So from the moment of the antibody binds to the cell, the moment the payload attempts to induce apoptosis. So we can have resistance on several levels. I think in practice, we can categorize this into three main buckets, as I would say. I think first, target-related resistance occurs when the tumor cell downregulates the antigen or develops mutations in the binding epitope. So actually, we're making the address between comas of the cell invisible to the ADC. We also can see some issues with internalization machinery. So if the cell stops recycling the receptor effectively, or if the ADC gets trapped in the endosome rather than reaching the lysosome, the payload is never released. So this is something that is impacting the delivery of the payload. Second, we can have payload-related resistance. And I think this is becoming more common with the widespread use of these topo-1 inhibitors. Cells can develop specific mutations on the topo-1 enzyme itself, or more commonly, they upregulate efflux pumps. So some ATP binding cassettes like MDR1. And these pumps actually act like a high-speed vacuum, ejecting the payload from the cytoplasm before it can reach the nucleus. And I would say the last one is tumor microenvironment, because like pancreatic cancer, if you have a desmoplastic stroma, it can create a very high interstitial pressure. And so there is a physical barrier, and it prevents these large molecules from reaching the core of the tumor, which can be also interpreted as a resistant mechanism. So I think this complexity dictates our sequencing strategies. It depends. So if a patient progresses on a topo-1 ADC, I think we must ask, is the target gone? Has the cell learned to pump out the drug? And if the target is still expressed, we might successfully sequence to another ADC with a different payload, such as a microtubule inhibitor, like a payload switch. However, if the resistance is driven by generalized efflux pumps, we may see cross-resistance between different ADC classes. So I think the future of sequencing will likely rely on repeat biopsies or liquid biopsies to identify which part of the ADC triad, as you said, antibody, linker, or payloads, has actually failed.
Thank you, Dr. Mansinho. I feel like there is limited evidence or limited data on the mechanism of resistance. And for breast cancer, at least, it seems like there could be multiple concurrent mechanisms. So it would be really hard to address this. Dr. Calvo, we always fear pneumonitis when giving ADCs, especially with trastuzumab deruxtecan. But there are other unique toxicities from ADCs that we don't see often with standard cytotoxic chemotherapies. Can you describe a few of them?
That is a key question, because many ADCs do not fail because they lack efficacy. They fail because toxicity limits the therapeutic window. In many cases, what we are delivering is an extremely potent cytotoxic drug with prolonged systemic exposure. So we still see classical chemotherapy-like toxicities such as myelosuppression, fatigue, nausea, neuropathy, or gastrointestinal effects depending on the payload. But ADCs can also produce a kind of more unique toxicities. Pneumonitis, for example, as you were alluding, Daniel, is one of the most important examples, particularly with some topoisomerase 1 based ADCs. It requires early recognition, prompt management, because if overlooked, it can become really serious. In this category of singular side effects, we also see ocular toxicities with some compounds, including dry eye or keratitis, and in selected cases, there is even the possibility of other type of potential toxicities on target of tumor effects when the antigen is expressed in normal tissues. So the practical message for general oncologists would be that ADCs are powerful drugs, but they require proactive monitoring, early dose adjustments, and familiarity with class-specific toxicities, which often depend on the payload type and how the ADC is engineered. Ultimately, one of the major challenges in this field today is to try to widen the therapeutic window, maintaining efficacy while reducing toxicity. And a better patient selection and smarter dosing, mostly centered on the payload component instead of the antibody component, may also help improve tolerability moving forward.
Thank you, Dr. Calvo. I feel like the hepatotoxicity sometimes becomes very problematic, and this is the non-specific uptake through FC, not the Fab, and with the recycling of the antibodies. And this is a little bit harder to treat than immune checkpoint inhibitors. Giving corticosteroids, which is what we do, doesn't work as fast.
You are totally right, Daniel. This is of a target of tumor toxicity. This is a chemotherapy type toxicity, but with the difference that these ADCs, the half-life of the payload is much longer. With chemotherapy, the half-life is hours. With these ADCs, the half-life of the payload might be days, sometimes over a week. So once that the payload is toxic to the liver, it is difficult to get rid of that because still the drug is in the patient's body. Yes, I agree. When that happens, sometimes it's not easy to manage that. That is why we need to really proactive in adjusting doses, etc. when this type of side effects occur. Totally agree.
Dr. Mansinho, we like to have a perfect biomarker in a way that the higher the IC expression, the higher chance of response. And that doesn't always happen. We look at breast cancer, trastuzumab deruxtecan may work even on IHC 0. So how can the ADC still be effective when there is little antigen expression? How come the expression by IHC does not correlate linearly with the responses?
That's actually a very, very good question, because I think this happened with a lot of biomarkers in which we use IHC to quantify them, such as PD-L1. I think immunohistochemistry is a static, semi-quantitative tool that we are using to predict something that is dynamic, and it's a biological process. So I think it has a natural inability to capture this bystander effect that we see first. And this is why we see clinical activity even in the biomarker low settings. So being a static snapshot for something that is biologically dynamic, and because ADCs can also release their payload outside of the cells, they can often deliver clinical benefit even in tumor that appeared negative on a traditional IHC slide. So I would say there are also 3 layers to why IHC is an imperfect predictor. So we have dynamic target expression, that's the first thing. Antigen expression isn't a fixed rate, it's a moving target, so it varies between the primary tumor, the metastases, even in different regions of the same mass. So that's pretty important. And more importantly, as we discussed in the article, there are targets that can be downregulated under selective pressure of the treatment, the ADC itself. So a biopsy taken 6 months ago may no longer reflect the tumor current's biology. I think that's something important. So I think we have an opportunity here for liquid biopsies, analyzing circulating tumor DNA or CTCs. That's becoming transformative right now. There are some trials, the Icarus Breast 101, for instance, in which we use CTCs or plasma DNA sequencing to track those changes in real time. And I think these circulating biomarkers will provide a pooled systemic view of the target landscape. So we'll probably be more accurate in defining the target real time rather than relying in the IHC determination. But having said that, I think the most fascinating scientific shift here is that internalization is not always strictly required. So the traditional magic bullet theory suggested that ADC must be internalized in the target positive cell to work. But we now know that modern ADCs are far more versatile. So this bystander effect that we see, so when we use payloads with high membrane permeability, like the deruxtecan we are talking about, or the SN38, for instance, the payload is also released not only inside the target cell, but it can diffuse across the membrane into the surrounding neighborhood. And this allows the drug to kill nearby cells that may have 0 or near 0 antigen expression. And furthermore, we are shifting towards linkers that are cleaved by proteases, and we know the microenvironment is rich in extracellular proteases. So in some cases, the linker can be cleaved outside the cell, releasing the payload directly into the stroma, and this creates a localized chemotherapy effect that IHC cannot simply measure. So for a clinician, and very simply, this means that a negative IHC result shouldn't necessarily close the door on that specific ADC therapy, such we are seeing in TDXD, especially if there is a strong bystander effect at play. So I think the future of patient selection is moving toward multi-model approach, using AHC to confirm the address exists, and then switching to liquid biopsies to see more functional approach, and how that addresses the tumor sensitivity over time, I would say.
I like the analogy to address. I'll start using it now. So I will start with Dr. Mansinho. And so how do you see the outlook for ADCs in solid tumors? What are the promising drugs? What kind of improvements can we expect from next generation ADCs? Hopefully, it looks like everything will be with cleavable linker, but hopefully an increased variety of cytotoxic or even non-cytotoxic payloads.
I would say we are no longer looking at ADCs such as a way to deliver precisely chemotherapy. We are designing molecules that can bypass resistance, tackle tumor heterogeneity, which is a bystander effect, and actually they can prime the immune system for, I would say, a more durable attack and sustained responses. When we look at the next generation of drugs, I would say three major upgrades might stand out. The rise of bispecifics, I think that's one thing. The dual payload ADCs as well. So the next generation will not be just one antibody with one drug. We are seeing, an uprise in the bispecific ADCs that can target two different antigens, like EGFR and HER3, for instance. It's having a very good traction, as we are seeing in lung cancer and also breast, where two different epitopes on the same antigen. I think this is critical because it forces the cell to internalize the drug more efficiently and prevents the drug from escaping just by losing one surface marker. We can design bispecifics in a and manner or manners in which we are increasing selectivity or broadening the activity. And we are also seeing dual payload ADCs carrying two different warheads, such as a topo-1 inhibitor and a microtubule agent. Also switching to immune payloads or such as radioligands. So I think this kind of dual payload ADCs will actually be something in the future. We are also broadening the target portfolio. So switching for the classic HER2, TROP2, the Nectin-4s, we are seeing GPC3s, Claudin 18.2. So actually very nice rationales. And I think that will also be something significant. And I think widening the therapeutic window has also been a challenge for us because of target toxicity is actually something, and as Emiliano was saying, something that limits the efficacy of ADCs, where the drug kills healthy cells generally. So next-gen engineering is solving this through site-specific conjugation. We have uniform drug-to-antibody ratios right now. The drug behavior is much more predictable. We are seeing linkers that are really amazing. And actually in phase 1, we are seeing activity at very lower dose levels than we used to with minimal toxicity. So I think we are seeing a very good improvement in the ADC structures. And I think masking will also be something very critical. So what we call the conditional activated ADCs or pro-ADCs, like we talk about them, where they stay inactive before they reach the microenvironment, then the mask is split, and then they unlock their toxicity payload. So I think this will be something very mindful. And I would say also combinational therapy, rather than dual payloads, but combining ADCs with immunotherapy, for instance, in which we induce immunogenic cell death and turn cold environments into hot tumors and leverage the ICIs to broaden their activity. So I think ultimately we are moving towards a future where we don't just pick an ADC because a patient has a certain cancer type, but I think we can have a more personalized approach and maybe go from there.
Thank you. Very good explanation. Dr. Calvo, it seems like the hope here is that maybe ADCs will replace cytotoxic chemotherapy, at least in some cases like bladder cancer. How do you see the field moving?
I also believe ADCs are entering their most exciting phase yet. The field is moving in two directions simultaneously from a clinical standpoint: combination strategies and earlier use in disease. Regarding combos, ADCs are biologically attractive partners for immunotherapy and targeted therapies with real potential to deepen responses and overcome resistance, taking advantage of their not fully overlapping side effects. And on the other hand, and at the same time, they are moving earlier in the treatment paradigms into first-line metastatic disease, as bladder cancer, as you were mentioning, and increasingly into neoadjuvant and adjuvant settings where cure may be the goal. And from a technological perspective, this is only the beginning. We are seeing smarter linkers, more precise conjugation methods, bispecific ADCs, and novel payloads beyond chemotherapy, including immune-modulating agents and dual payload constructs, as André was commenting on in further detail. So the opportunity is really extraordinary. The sky is the limit. But the next frontier is not simply building more and better ADCs. It is also learning how to use them intelligently, selecting the right patient at the right moment with the right dosage, dose and schedule of the ADC and the combination while preserving the quality of life of the patient.
That's interesting that we talk a lot about the antibody because it has to reach the target, and the payload, we don't talk much about linker. So it looks like we're going to use cleavable linkers, and the ideal linker will hold the payload during the circulation to prevent unconjugation, and it should release it inside the cancer cells. So what kind of linker improvement? So this is the goal, right? So what kind of linker linker changes could achieve that. I see the improvements. It's not very clear. How can this be improved? Is it a conjugation or?
That's crucial, especially I would say in terms of tolerance nowadays. Also anti-tumor activity, but the linker has an important role in tolerance. The ideal linker could be stable, will keep the payload with the antibody while it is in systemic circulation and will perfectly release the payload when it is inside the tumor cell. And this is not happening nowadays. Most of the linkers are cleavable and are not really achieving this goal. And actually, it is said that less than 1% of the ADCs get actually into their target, into the malignant cells. So here, again, we are aiming on bioengineering improvements to try to solve this. Well, so far at this point in time, there are not so many advances here as we see probably with payloads, receptors, etc. But definitely it is a way to go. We usually say that the toxicities of the ADCs is platform associated, especially the payload, but in reality is platform associated of the payload plus the linker. So that is an unmet need currently for ADCs.
I also agree. I mean, we need to improve linker technology. If we remember the first ADC in solid tumors, TDM1, we had a stable linker, which in theory was going to be just cleaved inside the cell, but actually TDM1 was very leaky. So it caused some off-target toxicity as well, mainly hematologic toxicity due to that. And I think this is something that we need to be mindful of when we address this kind of ADC development. Also, the DARs are very important because we had a switch to very high IDARs. And sometimes what we see when we have these leaky linkers, even if they are cleavable in theory just on the microenvironment, we see a lot of hematologic toxicity as we ramp up the dose. So we are having a lot of circulating free payload and we need to improve that selectivity. And I think that's key for us to be more specific and also improve the delivery because as Emiliano was saying, that 1% that reaches the tumor is quite unprecise because that, I mean, the question we might ask to everyone is where is the other 99% going?
I'm very thankful for this podcast. I just want to clarify for the listeners, DAR means drug-to-antibody ratio. There's the average number of payloads for each antibody. So this is all the time we have. I wish I could talk for like 3 hours, but I know they will cut me short very soon. Dr. Calvo, Dr. Mansinho, thank you so very much for participating. Thank you to our listeners. I encourage you all to read our wonderful antibody-drug conjugate supplement, which is now available to read in cancer, and we'll include a link to the podcast notes. Thank you, everybody.